Professor Chen and President Huang, and my co-chair, Dr. Xie. It's been a great honor to introduce, actually it's our immediate past Vice President of Taiwan, Professor Chen. He is a well-known scholarship. He got a lot of award and a lot of position in the world famous society or organization. He used to be a very famous epidemiology, especially in the field of oncology, cancer, and infectious disease. I remember that SARS attacked Taiwan. He was the Minister of Health Affairs and Welfare Affairs. Actually, before this is not called this name. And he have a lot of experience in contact or prevent or maybe cure or congenital of this infectious disease, especially with the COVID coronavirus. So today is our honor and privilege to have his talk about the recently COVID-19 situation in Taiwan and maybe prospect for the future. So let's welcome Professor Chen.
Thank you very much, Professor He and Professor Xie and President Huang, dear colleagues. It is really my pleasure and honor to give a presentation on COVID-19 containment and reform for resilience in Taiwan. As we all know, emerging infectious diseases always threaten human health and sustainable development in the world significantly. The catastrophic COVID-19 pandemic originated from Wuhan, China, has caused at least 566 million confirmed cases and 6.2 million deaths by April 21st, 2022, with a very significant GDP loss in almost all countries in 2020. And this slide shows the daily new confirmed COVID-19 cases per million people. As you can see on this slide, we compare with the South Korea, France, Germany, and Singapore, Canada, United Kingdom, Japan, United States, China, and India. As you can see, by April 19, 2020, Taiwan still have very low daily new confirmed COVID-19 cases per million. Our data is around 50 per million. It's much lower than the United States, Japan, United Kingdom. They are all above 100 per million. And for South Korea, France, Germany, and Singapore, they are more than 1,000 per million people. So far, we can see that this is a good situation. However, as you can see here from the slides, and there's Taiwan's incidence rate is increasing with recent weeks. And this slide shows there's an cumulative confirmed COVID-19 per million people. And as you can see here, from the April 1st, 2020 to April 19, 2022, within these 2 years, and as you can see, there's Taiwan's cumulative instance increased slightly, but during this mid-2021, we have alpha outbreak, so the case number increased rapidly, and then we have a level off of this cumulative confirmed COVID-19 cases, and recently we come up with this Omicron, and Omicron causes an increase of this newly diagnosed cases. But as you can see here, compared with France, South Korea, United Kingdom, Germany, United States, Singapore, and Australia, New Zealand, and so forth. And you can see that Taiwan has a much lower cumulative confirmed COVID-19 cases per million by April 19, 2020. And our data is on 1,508 compared with around 4 million. It means that, as you can see here, around 0.4 million. In other words, in France, around that 40% of the people in France already got infection. But in Taiwan, it's around 0.15% got infection. So our cumulative infection rate is much lower. And this slide shows the cumulative confirmed COVID-19 deaths per million people, and the same as this COVID-19 cases. You can see that Taiwan, the death number is much lower than United States, United Kingdom, France, and so forth. So you can see Taiwan has a lower COVID-19 deaths per million people by this April 19, 2022. And our data is higher than China. However, this in Oxford University, the Martin School of the Oxford University, they consider that in some countries, the COVID-19 deaths may not test for COVID-19. So they might die from other causes, so-called disease, other causes, but basically they will die from COVID-19. So Oxford University, Martin School, they developed a new indicator. The indicator is this estimated cumulative excess deaths. That's an all-cause mortality. If deaths from excess deaths per million, per 100,000 people during COVID-19 is a kind of a comparison. That's an all-cause mortality rate during the COVID-19 pandemic compared with this all-cause mortality before the epidemic. And as you can see, this is the excess estimated cumulative excess mortality. And in the whole world, there are 3 countries with this negative excess mortality. It means that the all-cause mortality during the COVID-19 pandemic is lower than non-pandemic period. And as you can see here, the Australia, Taiwan, and New Zealand have negative estimated cumulative excess mortality per 100,000 people. And China have positive excess cumulative deaths. So basically, Taiwan have good performance for the COVID-19 control. And everybody asks about this, how Taiwan can do it. And do we have very stringent control effort? In Oxford University Martin School, they also developed a new indicator that's so-called the stringency index. The stringency index is a composite measure based on the response indicator, including the school closure, workplace closure, or travel ban, and so forth. And the scale is from 0 to 100. If the 0 means there's not stringent at all, and 100 means that very stringent. And as you can see, in India, United States, United Kingdom, Canada, and in these countries, Taiwan have the lowest average of stringency index. In other words, in Taiwan, we are living normally, working normally, and going to school normally with the lowest stringency index, but we have the lowest mortality and lowest morbidity. So what's the global value in pandemic containment policy? I think the first one is the poor containment and belated reporting of the outbreak in Wuhan in December 2019. And there's a postponed announcement of public health emergency of international concern by World Health Organization until January 2020. So all of the countries have delayed the border control of passengers from Wuhan in February 2020. So, and at the very beginning, there's an insufficient tracing and testing system to identify close contact of confirmed cases for isolation. And a lot of countries carry out city lockdown but without the promotion of non-pharmaceutical interventions, including the wearing face mask, washing hands, social distancing, and avoidance of gatherings. And also, a lot of countries carry out the mass testing, but for those who were tested positive, they did not enforce the 14-day isolation. And there's also a shortage and panic buying of personal protection equipment, PPE, and have a limited response to disinformation dissemination. And the last but not the least is the lack of professionalism and political neutrality. And in the December of 2019, there's already a huge number of hospitalized COVID-19 cases in Wuhan. However, they did not report to WHO until this December 31st, 2019. On the December 31st, 2019, our Taiwan CDC officer aware of the atypical pneumonia cases in Wuhan. So we immediately sent an email to World Health Organization and also to China CDC. And on the same day, we started our onboard quarantine of passengers from Wuhan. So Taiwan took a very rapid response to this COVID-19 pandemic. And on this January the 2nd of 2020, we strengthened our suspected case reporting, and we have strengthened our hospital infection control of the healthcare system as well. And on this January 5th, Taiwan CDC organized the advisory committee, and on this January 7th, the level 1 travel notice for Wuhan was announced, and causal agent of COVID-19 was announced by WHO. And we have first cases imported from Wuhan on January 21st of 2020, and our president, Dr. Tsai Ing-wen, called an emergency meeting of National Security Council, and we activated our interministerial Central Epidemic Command Center. And I just mentioned that public health emergency of international concern was announced by World Health Organization until January 30th. So in Taiwan, our successful model for the COVID-19 content includes several important elements. They include rapid response, prudent action, rapid response, early deployment, precision intervention, transparency, public trust, and solidarity. I think the leadership is very important. And so we activate our Central Epidemic Command Center, and it is an interministerial coordination effort, and also try to promote the central and local government coherence and cooperation, and also ask for public and private partnership. And the chief commander of CCC was appointed by the president, and currently the chief commander is the Minister of Health and Welfare. And we also have organized a Science and Technology Advisory Board, and we have implemented several laws and regulations for epidemic control. And I think that professionalism and political neutrality are essential to build up public trust, and transparency and accountability are the best policy. And there are two phases of COVID-19 mitigation. The first one is interruption of viral transmission through non-pharmaceutical intervention. Our aim is zero COVID-19. It means that we don't want to have any cases of COVID-19. So we have implemented the border control, mandatory reporting and testing of suspected cases, hospitalization and isolation treatment of confirmed cases. And also we have to strengthen our hospital infection control, and all the inbound passenger from epidemic area has to be home or hotel quarantined. And we try our best to do cross-contact tracing, testing, and isolation. And we also implemented non-pharmaceutical intervention, that's wearing face masks and so forth. And school and workplace closure, we did not have workplace closure. We did have school closure for around 2 months during this summer of 2021, and we did not city lockdown. And this is the phase 1. After we have this vaccine, I think the phase 2 is the most important, is to increase this population immunity through the immunization, increasing the immunization coverage. And the aim is to live with the COVID-19. So different aim for different phase of COVID-19 mitigation. So I would like to share with you that in Taiwan, we did not have city lockdown, we did not have mass testing, but we use a lot of smart technology to help us to do the prudent surveillance of pandemic status, and also the rapid announcement of travel warning, and the stringent border control. We use this e-quarantine system, and we have intensive and comprehensive contact tracing and testing using ICT information and big data analysis. And we implement mandatory home isolation and quarantine using this digital fencing tracking system and line-bound system. And we did not carry out mass testing. Instead, we carry out precision or so-called targeted testing of reported suspect with this travel, occupation, clustering, and contact history. And also, we enhance this isolation treatment and hospital infection control. And as you can see in Taiwan, we have a very stringent border control. All the inbound passengers before boarding, they have to be tested and or have to present their vaccination record. And when they arrive at an airport in Taiwan, all the inbound passengers will get a health checkup and they have to be tested for COVID-19. If they were symptomatic and test positive, and they were delivered to hospital, and if they were asymptomatic, test positive, they were sent to the quarantine hotel, and they were discharged when they become testing negative. And for the stringent border control, when this inbound passenger arrive at Taiwan, and they have to we use this QR code web form to get their health declaration and basic information. And they were subject to a tracking system of disease control, and they were sent to this hospital, or if they were symptomatic, or they were sent to this quarantine place, and we set up the e-fencing system, and we provide services care to all the quarantined passengers. And in Taiwan, we upload all the information about the travel history, occupational history, especially for the healthcare personnel and the people who have the close contact with the patient and who participate in a large-scale clustering. All this information will uploaded to our National Health Insurance MediCloud. So all these physicians or pharmacists in Taiwan, they can go to this National Health Insurance MediCloud to get the information, the TOCC information of each patient. So from February to December of 2020, a total of 0.65 billion record search have been done by medical center, regional hospital, local hospital, pharmacists, as well as in private clinics. So using this way, we try our best to identify all the possible close contacts, all the possible infected people. And if we have this good information about the close contact, and we do contact tracing, checking, and testing. And this is a very important thing for us to identify all potentially infected people in Taiwan, and they are subject to home isolation and without spreading the virus in the community. So we identifying infection source of confirmed cases and potentially infected person. We test all close contact with potential infection. And if they were test positive and symptomatic, they go to hospital. If they were test positive without symptom and sign, they go to the quarantine hotel, and they were discharged when they were testing negative. And in Taiwan, we also use this smart technology to help us to identify this footprint of all the confirmed cases. And as you can see here, this is a track of the specific confirmed cases. He came to Taipei and go to Taichung and Kaohsiung and even go to Taitung and come back to Taipei. And we can identify all the hot zones of these specific confirmed cases. And we send out this a message to all these people who might have the potential, who might have this, who visited this hot zone during a specific time. I will give you an example of this Diamond Princess sightseeing tour. And when the cruise on a Diamond Princess arrived at the Keelung, that's around 2,000 tourists. They went to 60 tourist sites to go there for sightseeing, and we have to check in their hot zone, and then we send out around 0.6 million short message to the people who visited the hot zone during a specific period of time. And of course, you might wonder, how can we do that? Because this kind of contact information-based measure might invade the privacy. But in Taiwan, we are clearly informed all this cross-contact, and we assure that all the information we're keeping only for 28 days, and the data is only for the purpose of epidemic control, and the only contact investigation were done, and no further information were collected. And we assure the cybersecurity requirement. So basically, when we are collecting all this contact information, we are trying our best to have a very good balance between the privacy protection and disease control. And we have complied with all the law, including the Infectious Disease Control Act, Personal Data Protection Act, and cybersecurity management, and so forth. And the privacy issue is very important, and we assure that all the personal data are under very good protection. And through this way, we are following the principle of proportionality. Okay, and if someone who were isolated or quarantined at the quarantine place or at home, we set up this so-called e-quarantine system, the electronic fencing system. And if he left out of this e-fencing system constructed by the cell site, and then there's an alert message will send to local health authority, and the officer will visit him or her if he indeed left this quarantine place. They will get a fine. They will get a punishment, basically. And we also provide very good care and support services to isolated or quarantined person. We help them to have a meal delivery, garbage collection. We even arrange the settlement for them. And we also send them to the hospital if they got a symptom or sign. And every quarantined or isolated people will get the epidemic compensation of 1,000 Taiwan dollars per day. Okay, now you might ask a good question. You don't have city lockdown, you don't have mass testing, and you are living in a normal way. And how many people have been quarantined or isolated? I would like to share with you some of the information. By December 31st, 2021, there are a total of 93,721 close contact have been home isolated. And for those inbound passengers who were home quarantined or quarantined at the quarantine place, there's more than 950,000. So in total, we have more than 1 million people have been quarantined and isolated. And how many people have been tested positive? As you can see, there's more than 7,000 home isolated people become confirmed cases. In other words, they were tested positive when they were isolated, so they don't have any opportunity to spread out the virus in the community. In total, by the end of December 31st, we have around 14,000 cases, and 8,000 of them were isolated before they spread out the virus to the community. That's the reason why we very precisely controlled all the potentially infected people and isolated them to let them don't go to this community. And you will also ask the question, how many of them got a penalty? They left out of this e-fencing. And I would like to share with you that there's around 2,500 people have been got a fine. In other words, 99.7% of the quarantined or isolated people, they are complying with government regulation very well. They sacrificed 14 days of freedom to get that all the people in Taiwan can work together, work normally, go to school normally, and live normally. So we have to thank these 1 million unsung heroes because they sacrificed their freedom to get everybody work normally. And in Taiwan, in addition to this control of the epidemic, we also try our best to do that early deployment. So we we do our best to carry out the daily press briefing to announce transparent information, health education, and risk communication to resist disinformation attack. And we try our best to increase the adequate supply of PPE and other medical materials. And we also have a name-based e-rationing. We enforced non-pharmaceutical intervention. And we use e-allocation to implement our financial relief and economic stimulus. So through this way, in Taiwan, in the January of 2020, every day we have 1.8 million face masks. But in May 2020, the mass production reached 21 million. So, and through this way, everyone in Taiwan, including the kids, the young children, they have their own size of face mask. And we also do name-based distribution system to assure that everyone in Taiwan, they can have this, they may buy this face mask with a very low price. Okay, let us see. By the October 2020, the very famous U.S. National Bureau of Economic Research, they published a paper on this COVID-19 mortality and GDP loss. And as you can see, among the 40 countries compared, there's one country we call this an outlier country, because this country, Taiwan, has the lowest COVID-19 mortality per million people, and is the only country with the negative GDP loss. In other words, in 2020, Taiwan has lowest COVID-19 mortality and the highest GDP growth. However, Taiwan come across the limitation of this vaccination. In 2021, we did not have a vaccine as early as possible, so our vaccination program starting very late, as you can see on this graph. We start our vaccination program here. This is the green one, around 6 months later than the United States, this UK, or Singapore. But we have to thank Taiwanese people. They come out to get the vaccine very actively. So by April 19, 2020, the vaccination rate in Taiwan is among these countries with high coverage, such as the Singapore, China, South Korea, Canada, Australia, New Zealand, and Taiwan. We are here. And the share of people vaccinated against the COVID-19 by April 19, 2022, Taiwan is here. We have more than 76% people got this 2 doses. But one thing that I think is very important is the COVID-19 booster, vaccine booster. And Taiwan have the booster also much later than other countries because we start vaccination much later, so the booster should come also later. Then we start booster dose after this on December 21st. However, there's a booster shot, but for the time being is on 55%. It's better than in France, New Zealand, Australia, China, Japan, Canada, and the United States. So by January 4th, 2020, the Nikkei, Nikkei Asia have a so-called Nikkei COVID-19 Recovery Index. They compare this the epidemic control and vaccination coverage and social mobility to come up a recovery index among 120 countries. And Taiwan was ranked as the top #1. So by 2021, by the end of 2021, Taiwan is doing relatively good. So I would like to share with you that I think the successful containment of COVID-19 is based on the democracy, transparency, and solidarity in Taiwan. I just mentioned that from the very beginning of the pandemic, Taiwan government has assured that the public have the open access to COVID-19 information. And our Central Epidemic Command Center has held a daily press briefing since January 2020, which generate accurate news across a broad spectrum of media outlets, and CCC quickly established its authority and earned the trust of public health, of the public. And the public trust has had a stabilizing influence on society, encouraging citizens to follow government guidelines and rules, and making the public less vulnerable to disinformation campaign. So I would like to share with you that in Taiwan, there's virtuous cycles of good governance and good citizenship. The more the public trust, the more people are willing to cooperate. And as you might already know, transparency, public trust, and solidarity are the natural products of vibrant democracy in Taiwan. However, we have to pay attention to the people who have to the country who have a lower coverage of COVID-19, especially in Africa. As you can see, most countries in Africa, the at least one dose coverage of COVID-19 vaccine by April 19, 2020 is only less than 30%. And these are the countries where the future new variant might arise from these countries. So we have to help all these countries. We have, during our effort of vaccinating our way out of the pandemic, it is very essential to enhance this the development, manufacturing, distribution, and acceptance of the vaccine. And among this, I think the most important effort for the global vaccination effort is we have to solve the problem of the inequity and vaccine hesitancy, and also the immune escape variant. So the promotion of the vaccination, sharing and coverage, and the interruption of misinformation, disinformation are very important. So I think that in the future, for the prevention of the future pandemic, we definitely have to promote global solidarity and international collaboration. We all know that virus respect no border, and no country can fight the pandemic alone. And rapid containment of epidemic at its original site is very important. If the COVID-19 will controlled very well in Wuhan, dating back to December 2019, then we won't have the COVID-19 pandemic. So in the future, we have put out the fire when it is small. And World Health Organization needed to announce public health emergency of international concern quickly and transparently with professionalism and political neutrality. And for the reform for resilience, I consider that good governance and social cohesion is very important. And in the whole world, we definitely have to assure the equal access to PPE, diagnostic, antivirals, and vaccines among all countries. We should not have nationalism, and we should not have the deglobalization. So help each other through global solidarity and international collaboration is very important. And the last but not the least, I would like to share with you is that in the future, pandemic containment, we definitely have to apply science and technology breakthrough to contain the epidemic. One thing I would like to share with you that COVID-19 has changed the expectation of how fast the scientific breakthrough can be applied to pandemic containment. And the rapid identification of SARS-CoV-2 as the cause of COVID-19 and publication of its gene sequence has facilitated the rapid development of the diagnostic, antiviral, and vaccine. And in the future, digital technology, artificial intelligence, Internet of Things, machine learning, and big data analysis can be used for the implementation of non-pharmaceutical intervention. And innovative platforms now have been developed for the pharmaceuticals, like diagnostic, vaccine, and therapeutic. So for the future, I would like to conclude that we have to go for one planet, one health. It means that we have to promote the human health and to promote animal health as well as the environmental health. Through this kind of one planet and one health effort, and we can assure that in the post-COVID-19, a reform for resilience will be achieved, and then we can live in a better world in the coming future. And with that, I would like to thank you very much for your attention. Thank you.
And thank you, Professor Chen, for your very informative and inspiring talk, especially not only the medicine or for the future emergency infectious disease, but also all the political or probably interdisciplinary science development. So thank you so much. And now Professor Chen's talk will open for questions.
Okay, please.
Yes, please.
Can we send this? You may use this microphone.
Can you hear me?
Yes.
Okay.
Clear.
Okay. Thanks, Professor Chen. This is Dr. Chen speaking. You can call me Victor, okay? I have two questions. The first one, how about let's go back to the 20 years ago and the basic, okay? When SARS-CoV infect in Taiwan, the progress of the disease, let's review. First study, 3 to 5 days asymptomatic, right?
Yeah.
And then 3 to 5 days fever only. And then 3 to 5 days fever associated with COVID. And then 3 to 5 days, the patient will suffer from the massive lung infiltration, very serious lung disease.
Yes.
At that time, my teacher, my textbook, told me, suppose you run the endotrachea incubation, the people will die. The people will die. So, at that time, another way, use the past steroid. The past steroid inhibit the cytokine storm. The patient can survive, right?
Yes.
Okay, good. At that time, our conclusion is SARS-CoV produce antibody is enhanced antibody. Colloquial English say is bad antibody, just like the AIDS, GV12041, just like the dengue, right? But how come 20 years later, the virus changed to good guy? The antibody produced is neutralizing antibody. Colloquial English is say good antibody. Everyone, 1 dose, 2 dose, second dose, third dose, even the fourth dose. I tell you the truth. This is make us thinking process. Is any bias? And okay, my first question is, compared to SARS-CoV in 2002 and the COVID-19, the same coronavirus, that is a single strain RNA virus. They only invade the ribosome and use the RNA-dependent RNA polymerase to produce their protein and assembly one-step growth. How come? Please tell me. Please tell me the same virus, just 2 years difference, 20 years difference. One is bad antibody, the other is good antibody. This really makes me confused. This is the first question. The second question is, you are president of Taiwan. Nothing personal. I just want to inquire to you. If you have any difficulty to answer my question, that's okay. Okay, my question is, how come sample data in Taiwan didn't finish the 3-bench consistency? And some officer issued EUA, Emergent Use Authorization. We are a democratic country. This is public policy. Every life, this is our right. I think any government, any officer, they have no right to do that. So the second question you can answer me. Maybe you don't need to answer me. Okay? Thank you very much.
Good. Thank you very much for your question. With regard to the first one, you are trying to compare that's a SARS virus in 2003 and COVID-19 virus in 2019. Just as you mentioned that indeed, virus is always try its best to find its way out. Like said in the Jurassic Park, 侏罗纪公园, life will find its way out. So virus always keeping evolved and keep changing and try their best to infect a lot of people and don't kill the people they infected. So that's the reason why this SARS virus, when we got infection, we have very severe symptoms and signs, and then have a high fever, and the patient will hospitalized. And the virus has no way to spread out in the community. But COVID-19 is much clever. They have a very high, especially for the Omicron, they have very high infectivity, but very low virulence and very low case fatality. And it makes the virus can spread out much easier. And basically, I cannot answer your question why the SARS cannot induce this a good antibody and COVID-19 can. Or maybe we have to ask God why it evolved in this way. But indeed, as you mentioned that when there's a SARS outbreak, we try our best to produce, to do the production of the vaccine. But the pandemic was contained very quickly, so there's no way to do it. But for the COVID-19, since we have new platform, I think the reason why we may have the vaccine so quickly, because we have the new platform, that's a messenger RNA, a vaccine platform, and the second one is adenovirus vaccine platform. We have never used this before. And that's the reason why there's a lot of countries, not only Taiwan, issue the EUA for this new platform vaccine, such as a messenger RNA and adenovirus vaccine. So, and when people are using this kind of new platform to generate produce the vaccine, basically there's a new way World Health Organization is trying to promote. That's the so-called, that's on the immunobridging. It means that for those vaccines who were developed later than AZ, Moderna, and BNT, they may use the antibody titer, neutralizing antibody titer, as an indicator of the efficacy of the diseases. For instance, if you've got the 2 shots of the AZ, your neutralizing antibody is here, and if you got 2 shots of another new vaccine have a much higher neutralizing antibody, then we approve the vaccine. And this way of the new regulatory procedure, a so-called immunobridging. And immunobridging is proposed by World Health Organization. It's not only by Taiwan government. So I think that's the reason why we issued the EUA for Medigene vaccine is based on immunobridging policy. And of course, everybody can argue about that, but based on this clinical trial data, we found that after this 2 doses of Medigene vaccine, the antibody titer, neutralizing antibody titer, is much higher than 2 doses of AZ. And that's the reason why the MCV got this EUA use. And MCV is under the Solidarity trial sponsored by World Health Organization. World Health Organization sponsored Medigene's MCV to do phase 3 clinical trial, and the data is coming out in the coming June. So I just briefly answer your question about the vaccine. I think COVID-19 stimulates this new production of vaccine from a new platform. And we, of course, we have adopted a new regulatory policy for this new platform of the virus. Thank you very much.
Because of time limit, maybe we only allow one more question. Yes, please.
I'm sorry to take this opportunity to ask our Vice President, as the government policy is to live with the virus, everybody very concerned how long we can release our activities. I believe our Mr. President will be the good candidate to answer this question. How long it will take for Taiwanese to relieve their limitation, saying to take off their masks?
Okay, I think this is a very good question, and everybody is concerned about it. And I would like to tell you that, as you can see from from this slide, a lot of countries, such as I would like to show you one of the countries, that's South Korea. South Korea have very high daily newly confirmed cases, but now it's going down. And the United States too. United States already have a lower, that's an COVID-19 confirmed rate, but still higher than Taiwan. And so everybody worry about it because none of us have been, very few of us got the infection. And will Taiwan take another 1 year to recover from the COVID-19? And I myself consider that the coverage of the 3rd dose is very important. I just mentioned, by now, our 3rd doses coverage is only 55%. If we can reach that's as good as Israel, as more than 70%, I think it's the good time for us to take off our face mask. And it needs another 1.5 months to do that, because we started our vaccination program much later, and then so the booster dose will also reach this 70% much later. And for this Europe, for North America, for Australia and New Zealand, I predict by the end of June, they may took their face mask out. But in Taiwan, Taiwan people are more concerned about health, and I think the CCC has to reconsider that. But since Omicron has very high infectivity, and this all the regulations keep changing, have different so-called dynamic revision, and I think it's very important. And as you know today, that our quarantine day, home isolation day, is reduced from 10 days to 7 days. And I hope by the end of May, we may have a new regulation at that time.
Okay.
Thank you so much for your good answer. Hopefully, we can have a free activity, particularly for going abroad. Thank you so much.
Yeah. Yeah. Okay. Thank you very much.
Okay, thank you. Thank you once again, Professor Chen.
let's move on to the second topic for the session. It's my great honor to introduce the speaker topic, Dr. Haywood Brown. He now is at the University of South Florida, Tampa General Hospital. Dr. Brown has been the president of ACOG in 2017 to 18. On behalf of ACOG, Dr. Brown awarded me an honorary fellowship of ACOG in Austin, Texas in 2018. So I have met him several times in United States and in Japan. He graduated from Bowman Gray School of Medicine of Wake Forest University. I met a young guy. He's an OBGYN doctor in Austin. He told me, he's a Taiwanese American. He told me he was a student of Dr. Brown. He told me Dr. Brown is a very good teacher, and he respected him. And the topic today, Dr. Brown will give us is bariatrics obstetrics. We all know for a pregnant woman, obesity is a very big problem in the United States. The BMI is even between or about 50 to 100. So obesity is a very big problem for a pregnant woman in the United States. And let's begin the video, please.
Thank you for allowing me to give this presentation on bariatric obstetrics. I'm Haywood Brown from the University of South Florida, and I'm also past president of the American College of Obstetricians and Gynecologists. Our objectives for this presentation include the following. We're going to describe the prevalence of and the impact of obesity in the perinatal population. We're going to describe the weight gain recommendations and perinatal risk associated with obesity, including birth defects and stillbirth. And we're going to discuss delivery challenges from both a medical and surgical risk for women who are overweight or extremely obese. In general, obesity is not considered a medical complication of pregnancy. However, it is the most common chronic medical condition that complicates pregnancy in developed countries. And it has increased significantly over the past decade and a half. Here is a map of the United States that really describes the changes in obesity for about 30 years, from 1990 to 2017. Keep in mind that I'm here in the state of Florida, and prior to moving to Florida, I lived in North Carolina. The rate of obesity changed by 35% in 7 states, especially the extreme southern states, with the highest rate being changed in West Virginia and in the state of Iowa. More than 30% increase in obesity in at least 29 states. And the lowest rate of obesity was in the state of Colorado. And even it had a rate of 1/4 of the population. How do we define obesity in pregnancy? First of all, we define it as a gravid weight of greater than 200 pounds or a BMI greater than 90, not a BMI, a kilograms of greater than 90, and a BMI of greater than 30 kilograms per meter square. This is from the British Medical Journal, published in 2017, comparing the WHO classification of the various weight gain categories and proposed pregnancy classifications. As you'll note, the WHO classification, by these definitions of 30 to 40 or greater than 40 for the super obese, are different than the pregnancy-related categories. But in fact, the rates are quite significant for the number of participants that we had in this trial. What I want to show to you more importantly is over the course of about 5 years, from 2011 to 2015, how the rate of the obesity classes significantly changed over that period of time. Class 1 increased by 6%, Class 2 by 10%, and Class 3 by 14%. Women with a BMI of greater than 40 increased to almost 10% of the population that was being looked at. The other thing that we know is that there are adverse outcomes associated with being overweight, and particularly being obese. We're going to talk specifically about the risk of birth defects, neurotube defects, and cardiac abnormalities. We know that women who are obese have anovulatory dysfunctions and are more likely to have problems conceiving, and their chance of a conception increases significantly when they lose weight. We're concerned about the labor and delivery complications, as well as the fetal and neonatal death rate, which is higher. We're talking about stillbirth risk. We need to counsel all women on maternal complications like hypertension, gestational diabetes, and preeclampsia. And we also speak significantly about delivery of large for gestational age infants. And these are the things that we're going to discuss a little bit more. So when I counsel a woman antepartum about risk, I talk to her about the risk of developing chronic hypertension, the risk of developing pregestational diabetes or gestational diabetes, the risk for preeclampsia, which is clearly higher, particularly if they're nulliparous and older and obese, urinary tract infections. And one of the things that we don't talk about as much as we should is the risk of obstructive sleep apnea. Complications of obesity, intrapartum, are very concerning to the obstetrician because there is a higher risk for large for gestational age infants. For women undergoing vaginal delivery, there's a higher chances of developing a shoulder dystocia. And obviously, a significant concern with shoulder dystocia is brachial plexus injury. Anesthesia difficulties, particularly for those women who undergo an emergency cesarean and have to have a general anesthesia with intubation, more difficult intubation. And of course, there is a higher cesarean delivery rate. And so planning for delivery is extremely important in these patients. Here are the postpartum complications. Intrapartum, as well as postpartum, there's a higher risk of deep venous thrombosis, and as a result, a higher rate of pulmonary emboli. In fact, the risk of pulmonary embolic morbidity is higher postpartum in these women. And so it's important to follow all of the precautions that we follow at the time of cesarean in terms of DVT prophylaxis. The risk of endomyometritis, because these women may have labored or may not have labored. The chances of the uterus becoming infected postpartum is higher. Uterine injury at the time of cesarean delivery. Prolonged use of oxytocin for induction increases the risk of postpartum hemorrhage. Complications lead to longer hospital stays. And also there's a higher risk for wound morbidity, wound infections, and wound dehiscences, dependent on the type of this incision that is made at the time of cesarean delivery. One particular area of concern is the higher rate of stillbirth and the disparity in the rate of stillbirth between black women and white women, regardless of the obesity category. If you look at a normal weight woman's risk of stillbirth being the standard, and then look at all categories of obesity, the rate for stillbirth increases. The more overweight the woman is, the greater the chances of stillbirth. This is why these women are subjected to more antepartum surveillance. And in our practice for women with a BMI of 40, we start that antepartum surveillance at around 35 to 36 weeks. And we deliver these ladies no greater than 39 weeks. This is no longer considered an elective induction of labor, but an indicated induction of labor because of what I said, obesity being the most common pregnancy-related chronic condition. We have mentioned the fact that obesity is associated with stillbirths, and we've now mentioned the fact that it's associated with birth defects. People who are overweight and obese do have several metabolic abnormalities and various nutritional deficiencies. One of those being folate deficiency, which increases the risk for fetal neurotube defects. We're not quite sure why obesity is associated with birth defects other than what we're talking about. Maybe because of the metabolic abnormalities and the nutritional deficiencies, including folate deficiency. But we do know that when we combine diabetes with that, those women are more likely to have an abnormal glucose tolerance. Abnormal glucose tolerance is indeed associated with birth defects. Maybe that's independent of obesity or in conjunction with it, because diabetes is associated with increased risk of neurotube defect and cardiac abnormalities. And we know that obesity is also increased for cardiac abnormalities. So when we are trying to do an anatomic survey on ultrasound in the second trimester and trying to get images of the heart, is very critical to rule out these type of things, and it's often difficult to do depending on what the category of obesity we're dealing with in those patients. There are other serious medical complications associated with obesity. One that we don't talk about very often is acute fatty liver. Acute fatty liver is increased in women with a BMI of greater than 40. Non-alcoholic fatty liver more than 95%, and non-alcoholic hepatitis as high as 25%. One of the things that we see played out, particularly as it relates to maternal mortality, is the higher rate of cardiomyopathy. So a combination of being over 40, being of African descent, and being overweight or obese carries a higher risk for cardiomyopathy. And what we have found now that we know that maternal heart disease is one of the leading causes for maternal mortality here in the United States, the differential between coronary heart disease and cardiomyopathy really is about race and ethnicity. Black women are more likely to have a cardiomyopathy-related complication than white women. But look at the rate of obstructive sleep apnea. It's high. And what we know about obstructive sleep apnea is associated with lower oxygen saturations over a period of time, which impacts fetal growth, impacts the risk of undergrown, perhaps contributing to the stillbirth rate for under-surveyed pregnancies. But also, if that is associated with diabetes, obstructive sleep apnea is even higher and often undiagnosed. So sudden maternal deaths for extremely overweight women who are living at lower oxygen saturations, stillbirths in obstructive sleep apnea women, particularly at night, may be contributors that we need to care for. So these women who have a diagnosis need to indeed maintain their CPAP so that their oxygen saturations can be maintained. And this is one of the counseling things that we do with these patients. One of my areas of interest is what is the impact of overweight and obesity on normal labor and delivery. And my fellows and I have studied this over the course of time, particularly while I was at Duke University. And this is one study that we published in 2013 that looked at predictors of a failed trial of labor with women of a BMI greater than 40, even though their BMIs were significantly higher than 40 in the two categories. We only looked at women who had a greater than 275 pounds weight at the time of delivery, who attempted a trial of labor who were over 34 weeks. And we compared those having a successful vaginal delivery to those having a cesarean delivery. There were 357 pregnant women who weighed more than 275 pounds, who had a BMI greater than 40. And of these, 248 attempted a trial of labor. So it was a significant database. Now, what we found is that women who had a cesarean delivery had a greater BMI, well over 50, 51.6 compared to 49.9. They were more likely to be parous, 32 versus 65, and they were more likely to be induced, 80% versus 57.8%. When we compared those having a cesarean delivery to those who ultimately had a successful trial of labor and a vaginal delivery. Now, when we looked at a multivariate logistic regression model among nulliparous women, it really was the cervical dilation at the time of admission that was the most independent predictor of a cesarean delivery. The more favorable the Bishop score, the greater the chance of success. But also, as BMI increased by 10 kilograms per meter square, it was associated with a 3.5 increased odds for having a cesarean delivery. So the reality is BMI was an independent risk factor for predictive cesarean delivery, with cesarean delivery increasing further with the increase in BMI, although we really are not sure about the mechanism for the trial of labor for women who were in this obesity category. One other part of a study that we did, we'll talk about in just a minute, but I want to share with you as well that the characteristics of the women with the maternal characteristics were pretty much the same, except parity, and neonatal complications clearly were based on how dilated the person was and how successful they were with vaginal delivery. Of course, other things were not different. Shoulder dystocia obviously showing its face with this, and of course looking at cesarean delivery and postpartum hemorrhage, which we've already talked about for various reasons, including prolonged use of oxytocin, including maybe uterine injury and so forth and so on. This is another component of a study that we did that looked to see if there was a difference in the total duration of labor in the active phase for obese women versus very obese women. And we hypothesized there would be a difference, but in fact, there was no difference. And this is what we looked at. In the obese women, the mean weight was 219 pounds. In the very obese women, it was about 303 pounds, which was significant. And when we looked at the results in the length of active labor, what we found is that there was no difference in terms of hours, average minutes, and maximum minutes for the obese versus the very obese group. However, when we compared obese women to normal weight women, they had a significantly longer mean duration of labor in the active phase, with obese women having a slightly faster second stage. When we only looked at women who completed a vaginal delivery, only obese women had a longer labor in this study. What about VBAC? This was a study that was published in 2012 that looked at 30,000 singleton births with a VBAC rate of 2.3%. And people talk about there being a lower success rate for VBAC. But one of the other things they need to look at is neonatal death rate per thousand. The greater the rate of obesity, the greater the rate of neonatal mortality. If you look at women in this super obese category of greater than 40, it was 14.3% compared to the other two classes, or 4.1% versus 4.1 per thousand versus 4.5 per thousand. So correction, 14.3 per thousand, depending on the obesity category, with it being highest in the super obese group. It is extremely important to decide on the type of incision that you're going to make. Now, my preference is certainly for a Pfannenstiel transverse incision versus this super umbilical incision, which is associated with its own degree of complications, including wound separation. It also is important, though, to plan this because of getting to the uterus is very difficult in a cephalic. So sometimes you have to make a classical incision in the uterus, which increases the risk as well, as you can see here, and then increases the risk for wound uterine scar separation in subsequent pregnancies. Decrease the dehiscence rate because of a decreased thickness is really the reason that I prefer a Pfannenstiel incision if I can get away with it, but also there is an increased risk of infection due to the pannus falling over the incision. What I do is to strap this pannus and move it upward. So it gives me an opportunity to make this transverse incision here. Then I have to do care of this incision postpartum, keeping it wrapped, keeping it clean, keeping it dry over the first several days, and then seeing these women back early in the postpartum period to decrease their risk of wound complications. When we look at the overall postoperative complications in these patients, we're clearly looking at a higher rate of wound infections, wound disruptions, urinary tract infections, and I've also talked about blood loss, which really is associated with increased operative time, and we've also talked about thromboembolic complications. This is a study that was published in 2017 in the British Medical Journal. The total anesthesia time is longer depending on how overweight the patient is. You can see it begins to increase from normal to overweight to obese to super obese. Surgical time itself is really not that significantly prolonged from the perspective of delivering the baby. It's pretty much the same, but the total is clearly different. Anesthesia time, clearly different. When you look at the maternal fetal medicine unit network of cesarean deliveries, having at least one intraoperative complication, 3.4%, twice as frequent among those who underwent an emergency cesarean delivery, 6.4%. This is the reason that you have to think about certain things, like making sure you've had an anesthesia consult, making sure that the patient has an early placement of the epidural, making sure that you are concerned about those type of things. And the highest complication rate, obviously for women with the greatest BMIs of 50 kilograms per meter square. The other area that was looked at in the MFMU registry was the greater the BMI, the greater the risk for an ICU admission for whatever reason. And clearly you can see that this is a predictor of ICU admission, near-miss morbidity, and potential mortality. Very important to keep in mind. And this starts to go up at 30, but significantly changes at a BMI of 60, as you can possibly imagine. Cesarean site infection and wound care, extremely important. Published in 2010. These events cost a lot of money. You look at 27,500 surgical site infections a year in the cesarean population. This is the cost, $100 million for the cost of care. Quite significant. The burden of healthcare costs in this population undergoing cesarean delivery. So what are our recommendations? Certainly, if I have an opportunity to do preconception counseling, it's about weight loss, exercise program, preconception of folic acid use, and understanding what the patient's glucose tolerance is prior to going into the pregnancy. All very important. If we do weight loss, these women are more likely to conceive spontaneously and correct their ovulatory dysfunction. We have an opportunity to talk about this all the time in our preconception counseling women who are seeking infertility treatment. So we determine their BMI of all patients. We talk about weight loss, improving fertility, and decreasing the risk of spontaneous losses, stillbirths, and birth defects. We talk about the fact that obesity increases their risk for diabetes and hypertension and preeclampsia, operative delivery, blood loss, and thromboembolic. And we talk about how folate supplementation is associated with a lower risk for birth defects at the time of conception. So all these women ought to be on a preconception, a vitamin that contains folic acid. We also talk about what the weight gain recommendations are, and this is based on the 2009 Institute of Medicine calculations that suggested that women with a BMI greater than 40 only gain 11 to 20 pounds. What it didn't discuss is breaking down the categories of obesity from 1, 2, and 3, and how much weight gain could be a factor. And so people have looked at neutral weight gain or no weight gain, in comparison to women who've had more than the usual amount of weight that they should gain and fail to meet the Institute of Medicine guidelines. And here's what it showed. If you did weight gain below the Institute of Medicine guidelines of 10 pounds and looked at this group of 38% of the women, the rate of gestational diabetes was clearly lower. If you looked at gestational hypertension for women who gain less than the Institute of Medicine guidelines versus those who gain more, you can see how this looked compared to how this looked. No different. Gestational hypertension, no different. Whereas if they gain more, significantly different. Cesarean delivery, no different. Whereas if they gain more, higher. And of course, cesarean delivery, again, not as much of a factor as these things here for people who gain more weight compared to those who gain less weight. So what we do know is that not gaining up to the Institute of Medicine guideline does not necessarily have a negative impact on these patients in this population, particularly if they have a super obese definition of a BMI of greater than 50 or higher. When you look at the neonatal issues as well, for women who gain less than the guidelines, none of those things seem to be affected. Prematurity, very low birth weight, LGA was significantly lower, macrosomia not necessarily so, compared to those women who had weight gain above the Institute of Medicine guidelines, also not having any difference. So again, the impact neonatally in this group of gaining less than 10 pounds is not significant. And this is how we should counsel our patients. We also need to be concerned about the long-term impact. This study looked at that. For women who gain excessive weight during their pregnancy, they were 2 to 4 times higher risk for being overweight and obese 20 years later. And this contributes to the cardiovascular risk in women in their long-term health. At delivery, we meet with the anesthesiologist prior to needing pain relief. We think about shoulder dystocia. We plan the incision. We anticipate an increase in blood loss, and we talk about antithrombotic precautions. Now, what about pregnancy after bariatric surgery? This is a study in Israel that looked at 159,000 deliveries, 298 delivery of patients with previous bariatric surgery. What they found was that there still was an increased risk of macrosomia and an increased risk in obesity. And patients with a history of bariatric surgery were more likely to have labor induction and a cesarean delivery, primarily for the same things that we talked about. Overall, our prenatal care considerations should be these: screening, anesthesia consult when appropriate referral to a facility that can manage these deliveries, aspirin for preeclampsia as a precaution, ultrasound anatomy surveys to look for birth defects, fetal surveillance for the patient with a BMI of 40 because of the increased risk of stillbirth, and we start the conversation about bariatric surgery and appropriate contraception. We need to counsel the patient post-operatively about apnea. We need to have appropriate pain management. We need to have DVT prophylaxis. We need to give breastfeeding support because women who are extremely overweight have more difficulty breastfeeding, and they are the women who are most likely to benefit from breastfeeding, including their infants, because of the decreased risk for obesity, hypertension, and diabetes in those infants who have been breastfed. The biases. Providers are biased. They attribute negative stereotypes and believe obesity is strictly due to a lack of willpower. We know that's not the case, that everybody would lose weight. We subject these patients, unfortunately, sometimes to derogatory humor, which is unprofessional. And we need to make sure that we model with our trainees that this is not appropriate. This was a survey of physicians and weight bias. who suggested they felt more that these patients were non-compliant, lazy, lack of self-control, unsuccessful, unintelligent, and dishonest, and that's not the case. And they looked at almost 2,500 overweight and obese women, and they reported about 52% of them had been stigmatized more than once by their provider. If the provider was less likely to spend time with the patients, assigned more negative symptoms, and had reluctance to perform certain screenings. And that's a problem, because we looked at a study that suggests that the women who were very overweight were less likely to have weight gain recommendations given to them based on the 2009 recommendations, because they assumed they were not going to follow those weight gain recommendations because they were overweight. And that's wrong. We know that these patients are challenged with hormonal and central nervous system imbalances that makes it more challenging for them to sustain weight loss in terms of diet and exercise, and this is why bariatric surgery has become such an option for these patients. Very important for us to keep that in mind as we're counseling women. At least 85% regain their weight and more over time. Postpartum is a great opportunity for us to talk to the patient about achieving a healthier weight and also referring them for bariatric surgery if they meet the criteria for that. We need to educate medical providers about the risk, and we need to do a better job at counseling about all the things at the top of this list, including the issues that we are most concerned about. But maybe we need to be as concerned about stillbirth and other complications. We have to provide policies about care of the patients who are particularly in the super category. Intrapartum management, weight loss counseling postpartum. We have to make sure that we have the appropriate equipment available to even take a blood pressure. These are the type of things that increase our risk of liability as well. And this is what we have to keep in mind as we're caring for these patients who are indeed carrying the problem of the most common chronic medical complication of pregnancy that we see today. With that, I thank you and look forward to your questions.
Thanks, Dr. Brown, for his wonderful speech. Because the speaker is still not online, so let's close this session. Okay? Thank you. Thank you so much for your attendance.
Okay, finally, I would like to thank all the participants of TLG members, including 200 in Taipei, Taichung, Tainan, Kaohsiung meeting menu, and also more than 300 online. Okay, it's the first time have the AT joint meeting. I would thank the Professor Mark DeFrancisco to coordinate the meeting and invite the noble speakers from the ACOG. So it's very important, first step, to have a connection with the ACOG. Maybe in the next future, we can have the second and the third AT joint meeting in the future. And finally, I will thank to the moderator, Professor He Hongnen, Xie Qinghong, Su Hongxian, and the moderator in Taichung, the Ying Zhonghe, Zheng Yamin in Tainan, and also the Cui Guanghao in Kaohsiung, and also the Secretary General, the Huang Jianpei. Finally, I thank all the participants to enjoy the meeting, and hope the COVID-19 will fade away soon, and then we can return to normal activity in the future. Okay, thank you so much. Have a nice day.